Now, students, let us turn our attention to an important condition in the spectrum of metabolic bone diseases, rickets. As you can see in the text before us, rickets refers specifically to the failure of proper mineralization in the growing skeleton. That phrase, growing skeleton, is crucial. Rickets occurs in children, while in adults the counterpart is osteomalacia. So when we speak of rickets, we are talking about bones that are still actively elongating at the epiphyseal plates, and this failure of mineral deposition leaves the bones soft, pliable, and prone to characteristic deformities. Historically, rickets was far more common than it is today. If you imagine the industrialized cities of Northern Europe during the 18th and 19th centuries, where children labored indoors and sunlight was scarce, vitamin D deficiency was rampant. Without the ultraviolet light necessary to stimulate vitamin D synthesis in the skin, calcium absorption falters, phosphate balance is disturbed, and the child's bones are left undermineralized. Severe bowing of the legs, widening of the wrists, and deformities of the thoracic cage were textbook images in the early days of orthopedics. In fact, many of the classic case descriptions in orthopedic literature from the early 20th century came from children suffering from nutritional rickets. Now, the passage reminds us that in developed nations today, simple nutritional rickets is rare. With fortified foods and better public health, most children obtain adequate vitamin D and calcium. However, we as clinicians must remain vigilant because rickets can still appear de novo. Sometimes families avoid dairy or sunlight exposure is limited due to cultural practices, or the child has malabsorption syndromes. All of these can set the stage for rickets even in modern hospitals. So while it is uncommon, it is not extinct. Beyond nutritional deficiency, we must also remember the inherited causes. These are the forms of rickets you will encounter more frequently in well-resourced settings, particularly in pediatric orthopedic clinics. Genetic disorders such as X-linked hypophosphatemic rickets or defects in vitamin D metabolism may present with the same bowed legs or growth disturbances, but the underlying mechanism is very different, and this is where your diagnostic skill becomes critical. The text also emphasizes renal tubular abnormalities. This is another crucial point. The kidney is a central regulator of phosphate balance and vitamin D activation. In renal tubular acidosis, or in conditions where phosphate wasting occurs, you get secondary rickets. Moreover, in chronic kidney disease, children may develop what we call renal osteodystrophy, a complex picture where features of rickets overlap with those of secondary parathyroid hyperplasia. That means you may see the skeletal softening of rickets combined with the high bone turnover and resorption caused by excessive parathyroid hormone levels. One important clinical pearl is this. No matter the cause, whether nutritional, genetic, or renal, the outward manifestations of rickets are strikingly similar. The child may have bowing of the legs, delayed growth, widening of the growth plates, and sometimes the so-called rickety rosary, which are bead-like prominences at the costochondral junctions of the ribs. Because these features are nonspecific, the clinician must always look deeper into the etiology. So as we move forward in our discussion, I want you to keep in mind two levels of understanding. First, the surface level, recognizing the clinical appearance of rickets, which examiners will surely test you on. And second, the deeper level, the pathophysiology, the multiple routes by which mineralization can fail, and the way in which you tailor your management depending on whether this is a simple case of vitamin D deficiency or a complex renal or inherited disorder. In the next section, we will go through those etiologies in more detail, but for now, I want you to hold on to the concept that all rickets looks similar at first glance. Your role as a future doctor is to differentiate the cause because that is what determines the treatment.
Let us carefully examine how rickets presents clinically, both at the bedside and on radiographs, because this is exactly the kind of material that examiners love to test, and more importantly, It is what you will encounter when faced with a child who may carry this diagnosis. At its core, rickets is the failure or delay of calcification at the long bone physis, the growth plates. This is why you see its most dramatic effects in children whose bones are still elongating. When the physis cannot properly mineralize, it not only slows down longitudinal growth, but it also produces abnormal, asymmetric forces on the bone, leading to angular deformities. Alongside rickets, you often find osteomalacia in children. Remember, osteomalacia is the failure of mineralization of osteoid at the cortical and trabecular surfaces. So while rickets affects the physis, osteomalacia softens the entire skeletal framework. In adults, where the growth plates have fused, only osteomalacia occurs, but in children, both processes often coexist. The skeletal abnormalities of severe rickets generally manifest early, often before the age of 2. These children may already have a history that points toward underlying hypocalcemia during infancy. Think of convulsions, tetany, apneic spells, or stridor before 6 months of age. These are the warning signs that calcium metabolism was failing long before the bone deformities became obvious. When you examine the child, you often find hypotonia, delayed milestones such as sitting, crawling, and walking, and proximal muscle weakness. Parents may report that the child sweats profusely, especially during the night, and in severe cases, cardiomyopathy or recurrent respiratory and gastrointestinal infections can complicate the presentation. This constellation is important to keep in mind. Rickets is not just a skeletal disease. It can affect multiple systems, particularly in its severe nutritional form. Skeletally, deformities can be seen at almost every physis. The wrists and knees are often thickened, the elbows too. The long bones are short for age and may bow, producing genu varum or genu valgum. The proximal femur may show coxa vera, a deformity that reduces the angle between the head and shaft of the femur, impairing gait. The chest carries some of the most characteristic signs. Costochondral enlargement produces the so-called rachitic rosary, those bead-like prominences along the rib cage. Just beneath, the Harrison sulcus can appear, an indentation at the lower rib margin caused by diaphragmatic pull against softened bone. The spine is not spared, with kyphoscoliosis occasionally developing. The skull reveals further signs: delayed closure of the anterior fontanelle, frontal and parietal bossing, and sometimes plagiocephaly, where the skull is misshapen due to positional pressure against its softened surfaces. Dentition is delayed, so the child may be well past the expected age for eruption of primary teeth without any appearing. Now, let us shift to radiographic findings, because the X-ray is often where the diagnosis is cemented. The hallmark is widening and indistinctness of the growth plates. Under normal conditions, the gap between metaphysis and epiphysis at the distal radius should never exceed 1 millimeter. In rickets, that line blurs, becoming widened and fuzzy. With weight bearing, there is lateral expansion of the growth plates, explaining why crawling children develop thickened wrists and knees. The growth plates broaden under mechanical load. The long bones themselves take on a classic cupped and splayed appearance. The long bones, as you would expect, appear short for age. Deformities such as genu varum, genu valgum, or coxa that you observed clinically are reflected clearly in their radiographs. Radiographic evidence of osteomalacia also appears. Here we see the so-called looser zones, or pseudofractures, transverse bands of unmineralized osteoid, most often located in the medial aspect of the proximal femur or the posterior ribs. Around these pseudofractures, an osteosclerotic reaction forms, but in adults, these zones may progress into true fractures if left untreated. Other late signs include acetabular protrusion and pathological fractures, reflecting profound weakening of the skeleton. So, to summarize this section in your mind, the clinical picture of rickets is both systemic and skeletal. Delayed milestones, weakness, sweating, cardiomyopathy on one side, and bowed legs, ricketic rosary, Harrison's sulcus, and frontal bossing on the other. The radiographic hallmarks, widened growth plates, metaphyseal cupping and splaying, and looser zones complete the diagnostic triad. When you see this combination, you must think beyond "this is rickets" and ask, what is the cause and how do I tailor management to that underlying etiology?
If you look at Table 6.2, you will see the classification neatly arranged according to what is lacking at the osteoblast-bone interface. This is an elegant way of conceptualizing the problem. Bone cannot mineralize unless three conditions are satisfied. There must be adequate calcium, adequate phosphate, and the enzyme alkaline phosphatase must be active at the site of mineralization. Disturbances in any one of these three pillars will lead to rickets. On the calcium side, we have the classic nutritional rickets, usually due to vitamin D deficiency. But there are also rarer causes, isolated calcium deficiency in the diet or combined calcium deficiency with marginal vitamin D intake. There are also gastrointestinal causes where absorption is impaired, such as in celiac disease, Crohn's disease, ulcerative colitis, or chronic liver disease interfering with bile salt metabolism. In addition, you may encounter the rarer scenario of end organ insensitivity to vitamin D, where calcitriol is present but the receptors cannot respond, leading to a functional deficiency. On the phosphate side, the most important condition is X-linked hypophosphatemia, the most common inherited cause of rickets, but you may also see phosphate wasting in renal tubular abnormalities such as Fanconi syndrome. And finally, in the rarest corner, we have hypophosphatasia, where alkaline phosphatase itself is deficient. Now, let us first complete our discussion of nutritional rickets, because it is the historical prototype. We know that vitamin D deficiency is the principal cause. Without vitamin D, calcium absorption in the gut fails, serum calcium falls, parathyroid hormone rises, and the skeleton is robbed of its mineral supply. But the story is a little more nuanced. It is possible, for example, to develop rickets in the presence of adequate vitamin D intake if calcium itself is profoundly deficient. This is increasingly recognized among certain populations where the diet is naturally low in calcium and high in phytates or oxalates, substances that bind calcium and render it unavailable. This combination of low calcium and marginal vitamin D intake has been described in modern Asian populations in the United Kingdom and in Black populations in the United States, as well as among adolescents who avoid dairy or sunlight. In these cases, parathyroid hormone drives increased vitamin D catabolism, worsening the deficiency state.
Vegetarians, particularly those avoiding dairy, are at risk, as are children living in northern latitudes where sunlight exposure is inadequate in winter. For example, at 39 degrees north latitude, such as Cincinnati, 2 hours per week of summer sunshine is enough to produce vitamin D in the skin, but at 52 degrees north, such as Edmonton, the UVB exposure in winter months is insufficient. A Canadian survey showed at least 3 cases per 100,000 children, with higher prevalence in breastfed infants and in children of northern communities. Clinically, these children present between 3 and 18 months of age, often with delayed milestones, hypocalcemic seizures in infancy, and the classic skeletal deformities that we reviewed earlier. Laboratory findings include low or normal serum calcium, low phosphate, low serum 25-hydroxyvitamin D, and high alkaline phosphatase. One useful point for your exams: alkaline phosphatase is almost always elevated in rickets, but it normalizes once therapy is successful. Treatment of nutritional rickets is straightforward, but must be adequate. We use vitamin D in doses of 5,000 to 10,000 IU per day for 4 to 8 weeks, combined with calcium supplementation of 500 to 1,000 milligrams per day. Once biochemical and clinical normalization occurs, maintenance vitamin D is given at 400 to 800 IU daily. For difficult cases, single high doses of vitamin D, 200,000 to 600,000 IU orally or intramuscularly, have been used with good results, though careful monitoring is required to avoid toxicity. And do not forget sunlight exposure itself. 2 hours per week of sun on the face and arms is enough in summer to maintain adequate vitamin D production. Now, let us consider gastrointestinal rickets. Even if calcium and vitamin D are present in the diet, diseases that impair absorption will produce the same clinical picture. Celiac disease, Crohn's, ulcerative colitis, and short gut syndromes are well-known causes. Liver disease can also interfere, since bile salts are necessary to absorb fat-soluble vitamins like vitamin D. The treatment here is twofold: correct the underlying gastrointestinal disease and supplement the missing nutrients. And finally, let us move to the most important inherited form, X-linked hypophosphatemia. This is by far the most common genetic rickets, with a prevalence of about 1 in 20,000. It is transmitted as an X-linked dominant trait, which means both males and females are affected, though a ratio of female to male cases is about 2 to 1 because male-to-male transmission does not occur. The genetic defect lies in the PHEX gene, which normally regulates renal phosphate handling. In its absence, phosphate wasting occurs in the proximal tubules, leading to chronic hypophosphatemia. Unlike nutritional rickets, where vitamin D deficiency is the culprit, here the problem is renal phosphate loss. Another key point: in X-linked hypophosphatemia, serum 1,2 dihydroxyvitamin D levels are inappropriately low or normal, despite hypophosphatemia. The body fails to increase calcitriol production, which worsens the mineralization defect. Clinically, these children show rickets, short stature, and the skeletal deformities that we have already described. One very characteristic feature is dental abscesses even before dental caries appear due to defective dentin mineralization. Adults may develop osteomalacia with degenerative joint disease, enthesopathies, and persistent short stature. Treatment involves oral phosphate supplementation divided into multiple daily doses and active vitamin D analogs like calcitriol. This treatment requires careful monitoring because overcorrection can cause secondary parathyroidism and soft tissue calcification.
Historically, vitamin D was used in very high doses with toxic side effects, but with calcitriol and phosphate supplementation together, outcomes are much better. Still, angular deformities such as genu valgum or genu varum often require surgical correction with osteotomies. So, if you step back, you now see how the framework applies. Nutritional rickets, a problem of calcium and vitamin D supply. Gastrointestinal rickets, a problem of absorption. X-linked hypophosphatemia, a genetic problem of phosphate wasting, and in the rarer corners, renal osteodystrophy and hypophosphatasia. Clinically similar, but metabolically distinct.
We begin with 1-alpha hydroxylase deficiency, historically called vitamin D-dependent rickets type 1. This condition was first described in 1961 by Prater, when he noted children with severe rickets who failed to respond to ordinary doses of vitamin D. At first, they were treated with huge doses of vitamin D, but later it was understood that the defect was not in the availability of vitamin D itself, but in its activation. Recall that vitamin D3, or cholecalciferol, must undergo hydroxylation in the liver to form 25-hydroxyvitamin D, and then a second hydroxylation in the kidney at the 1-alpha position to form calcitriol, the biologically active metabolite. These children lack the 1-alpha hydroxylase enzyme, and so although they have plenty of 25-hydroxyvitamin D, they cannot convert it to 1,25-dihydroxyvitamin D, the active form. Clinically, they present very early, often before 6 months of age, with weakness, pneumonia, seizures, bone pain, and of course the skeletal signs of rickets. Their serum shows low calcium and phosphate, high alkaline phosphatase, and parathyroid hormone that may be normal. The telltale sign is the combination of normal 25-hydroxyvitamin D but severely reduced 1,25-dihydroxyvitamin D. The genetic pattern is autosomal recessive, and multiple mutations in the gene have been identified. The beauty of this disorder, however, is that treatment is simple and effective. We bypass the defective enzyme by administering calcitriol directly. This restores mineralization and cures the rickets. Next, let us consider end organ insensitivity to vitamin D, also known as vitamin D-dependent rickets type 2. This was first described by Marks in 1978 in Two Sisters. Here, the unusual feature is that the body produces plenty of calcitriol. Levels can be 10, 20, even 30 times above normal, but the receptors in the tissues cannot respond. The child is essentially resistant to the hormone. Clinically, one of the striking features is alopecia, either partial or complete, affecting both scalp and body hair. This is a very helpful exam clue. If you are given a vignette of a child with rickets and alopecia, think of vitamin D resistance. Laboratory findings show elevated calcitriol but failure to mineralize bone. Treatment is much more difficult. Very high doses of calcitriol have been tried, as well as high-dose intravenous calcium followed by oral supplementation, but the response is incomplete. This is one of the rare forms of rickets where medical therapy is unsatisfactory. Now we turn to renal tubular abnormalities, a large and diverse group that falls under the umbrella of Fanconi syndrome. In these disorders, the proximal tubules of the kidney fail to reabsorb small molecules, phosphate, calcium, bicarbonate, sodium, potassium, amino acids, glucose, uric acid, all are lost in the urine. The result is profound disturbance of mineral homeostasis. For our purposes, the key point is phosphate wasting, which leads to hypophosphatemic rickets, very similar to the X-linked form we already discussed. In addition, if the kidney disease is advanced enough to impair 1-alpha hydroxylation, there is a deficiency of calcitriol as well, producing a mixed picture. This combination of phosphate wasting and calcitriol deficiency is what we term renal osteodystrophy. Treatment follows the same principles: oral phosphate, active vitamin D, and management of the underlying renal disease where possible.
Finally, let us discuss hypophosphatasia, perhaps the rarest but also one of the most distinctive conditions in this group. Unlike the other forms we have covered, which involve calcium or phosphate supply, here the defect lies in the enzyme alkaline phosphatase itself. Without alkaline phosphatase, mineralization cannot proceed, and the skeleton develops severe rickets in childhood or osteomalacia in adulthood. This is a recessive condition, and over 100 mutations in the alkaline phosphatase gene on chromosome 1 have been described. Clinically, these patients may present with rickets, with pathologic fractures, or with osteomalacia in adulthood. Dental abnormalities are very characteristic. Because dental cementum fails to form properly, the primary teeth are lost prematurely, often with intact roots and minimal resorption. Children may also suffer from failure to thrive, raised intracranial pressure, or craniosynostosis. The severity varies. There is a perinatal lethal form where infants die shortly after birth, a childhood form with remission at adolescence, and an adult form with mild osteomalacia and pathologic fractures. Unlike 1-alpha-hydroxylase deficiency, here treatment is extremely challenging. There is no effective pharmacologic cure. Bone marrow transplantation has been attempted experimentally with the hope that donor osteoblasts producing alkaline phosphatase could repopulate the skeleton. Surgical management is often required, but difficult, because the abnormal bone heals poorly. Still, techniques like intramedullary rotting have shown better outcomes than plating in stabilizing fractures.
Now, students, let us finish our comprehensive journey through the many phases of rickets by focusing on renal osteodystrophy, a particularly complex but highly relevant entity that you will encounter in nephrology wards and orthopedic consultations alike. Renal osteodystrophy describes the skeletal changes that develop in the setting of chronic kidney disease, particularly in those patients approaching end-stage renal failure and requiring dialysis. Here, the bones are not only under-mineralized, but also remodel abnormally under the influence of profound disturbances in calcium, phosphate, and parathyroid hormone. Thus, it represents a spectrum that combines rickets, osteomalacia, and secondary hyperparathyroidism, often in varying degrees. Let us trace the pathophysiology step by step. When renal function drops below roughly 25 to 30% of normal, the kidneys can no longer adequately clear phosphate. Hyperphosphatemia develops, which reduces serum calcium by shifting the solubility equilibrium. The fall in serum calcium stimulates the parathyroid glands to secrete more parathyroid hormone. This is secondary hyperparathyroidism. Prolonged stimulation eventually produces parathyroid hyperplasia, and in some cases, the glands may become autonomous, continuing to oversecrete PTH even after transplantation. In that scenario, we call it tertiary hyperparathyroidism. The clinical and radiographic consequences of this disordered physiology are dramatic. One hallmark is the formation of brown tumors, which are expansile, destructive bone lesions that resemble neoplasms but actually represent areas of intense bone resorption, replaced by fibrous tissue and hemorrhage. Look at Figure 6-5. Here in the pelvis, you can see the destructive changes in the femoral shafts and ischial rami, appearing much like metastatic lesions, but in fact due to secondary hyperparathyroidism. Another characteristic change is subperiosteal resorption, classically seen along the radial margins of the middle phalanges of the index and middle fingers in adults. In children, these erosions may be evident at the distal radius, ulna, or medial tibial metaphysis, as shown in Figure 6-6. Note in this child the combination of sclerosis, soft tissue calcification, and resorption, evidence of the chaotic bone metabolism of renal osteodystrophy. We also see the radiographic features of rickets and osteomalacia.
Widened growth plates, metaphyseal cupping, varus or valgus deformities of the knees and ankles, and loser zones. Figure 6-7 demonstrates one such loser zone in the medial femoral diaphysis. These pseudofractures are transverse bands of unmineralized osteoid, vulnerable to progressing into full fractures. A particularly important orthopedic complication is the increased incidence of slipped capital femoral epiphysis, SCFE. Look at figure 6-8A. In this 12-year-old boy, we see an early slip on the right. This complication occurs more frequently and at a younger age in renal osteodystrophy than in other forms of rickets, owing to the weakened physis and the general growth retardation of these children. 3 years later, as seen in figure 6-8D, fixation has stabilized the right side, but the left hip has now developed avascular necrosis and fragmentation. This illustrates the chronic, bilateral, and evolving nature of the skeletal disease in renal osteodystrophy. When you approach the treatment, it is not enough to think only in orthopedic terms. You must remember the underlying renal and endocrine disturbances. Management involves a combination of dietary phosphate restriction, phosphate-binding agents, often calcium-based, and vitamin D therapy, specifically calcitriol, the active form, which helps suppress secondary parathyroidism and improves mineralization. Successful renal transplantation often improves the skeletal manifestations, but as I mentioned, if the parathyroid glands have already become autonomous, tertiary parathyroidism may persist, sometimes necessitating parathyroidectomy. Orthopedic intervention is often required for deformities. Angular deformities of the lower limbs may require osteotomy. Slipped capital femoral epiphysis usually requires stabilization, often bilaterally. Pinning techniques are preferred, but surgeons must be mindful of the soft bone quality in these patients, as hardware cutout can occur if hyperparathyroidism is not well controlled.